There is a version of trauma that most people recognize. A car accident. A natural disaster. A violent assault. Something sudden, discrete, overwhelming, an event with a clear before and a clear after, a moment that the person can point to and say, that is when everything changed. And then there are the versions most people do not recognize, or do not recognize as trauma. The childhood that never contained a single dramatic event but was organized, for years, around the emotional volatility or unavailability of a parent. The workplace that systematically undermined and isolated a person over 18 months. The relationship that was never violent in a way that left marks anyone could see but that gradually, methodically, dismantled the person's sense of reality. The therapist, the first responder, the nurse who has absorbed, year after year, the weight of other people's worst moments. All of these are trauma. They present differently, they persist differently, they require different treatment approaches and different healing timelines. And conflating them, treating them all as a single phenomenon that responds to a single intervention, is one of the most significant errors in both popular understanding and clinical practice. Today we are building the complete map, the 4 major categories of trauma: acute, complex, chronic, and secondary. What each one is, how each one presents in the body and in behavior, how they differ from each other, and what the differences mean for healing. The worksheet covering all 4 types is linked in the description. Let's start with the foundation. Section 1. What trauma actually is, the foundation. Before we can meaningfully distinguish between trauma types, we need a precise definition of trauma itself, because the word is used so broadly in contemporary culture that it has, for many people, lost its clinical specificity. Trauma, in the clinical sense, is not simply a bad experience. It is a response, a specific neurobiological response, to an experience that overwhelms the person's capacity to cope, integrate, and process in the moment it occurs. The key phrase is overwhelming the capacity to cope. Trauma is defined not by the event itself but by what the event does to the person's nervous system and their ability to process and make meaning of what has happened. This definition has 2 critically important implications. The first is that the same event can be traumatic for one person and not for another, because people have different nervous system sensitization, different histories, different available resources, and different prior experiences that shape their capacity to absorb and process what happens to them. The absence of a traumatic response to an objectively terrible event is not evidence of strength or superiority. And the presence of a traumatic response to an event that others minimize is not evidence of weakness or fragility. It is evidence of a specific nervous system responding to a specific experience in a specific context. The second implication is that trauma lives in the body and in the nervous system, not primarily in the event itself. Bessel van der Kolk's foundational insight, "The body keeps the score," is not metaphorical. The traumatic experience is stored as sensory and somatic impressions, as nervous system dysregulation, as implicit memory that is activated by present moment triggers without conscious awareness or choice. This is why trauma can be fully present in a person who cannot articulate a traumatic narrative, because the trauma is not primarily a story. It is a physiological state. And understanding this changes everything about how we approach both identification and treatment. With that foundation in place, let's look at the 4 types. Section 2, Type 1, Acute trauma. Acute trauma is what most people picture when they hear the word trauma. It is the response to a single, discrete, time-limited event, an event that has a clear beginning and end, that is experienced as suddenly overwhelming, and that produces an intense psychological and physiological response in its immediate aftermath. The events that produce acute trauma span an enormous range: accidents, assaults, medical emergencies, natural disasters, witnessing violence, sudden unexpected loss, or any other experience that confronts the person abruptly with threat, helplessness, or horror. What they share is the quality of discreteness. The event is distinct from ordinary life, sudden in its onset, and overwhelming in its immediate impact. The acute stress response that follows typically includes a combination of intrusive re-experiencing, flashbacks, nightmares, sensory memories that intrude into waking consciousness, hyperarousal and hypervigilance, avoidance of reminders of the event, and a range of emotional responses including fear, grief, anger, guilt, and the numbing or emotional blunting that represents the nervous system's attempt to modulate an unbearable experience. For many people, acute trauma responses resolve within weeks to months as the nervous system gradually processes the experience, the person re-establishes safety and routine, and the intrusive symptoms diminish. This natural recovery process, supported by social connection, adequate safety, and time, is the expected trajectory. When it does not occur, when symptoms persist beyond the acute period and continue to significantly impair functioning, the diagnosis of post-traumatic stress disorder becomes relevant. PTSD, which the DSM formally defines in terms of criteria including re-experiencing, avoidance, negative alterations in cognition and mood, and hyperarousal, is most directly associated with acute trauma. Its diagnostic criteria were developed largely from research on combat veterans and disaster survivors, populations whose trauma was primarily acute and event-based. This origin matters, because it means the PTSD framework, as powerful and as important as it is, was built around a specific type of trauma experience that does not capture the full range of what trauma produces in human beings. The treatment approaches with the strongest evidence base for acute trauma, including prolonged exposure, EMDR, and cognitive processing therapy, are specifically designed for the processing of discrete traumatic memories, and they are highly effective for this purpose. For acute trauma with a clear traumatic event to process, these approaches are among the most powerful interventions available. Section 3, Type 2, Complex trauma. Complex trauma is the type that is most frequently misidentified, most frequently undertreated, and most frequently responsible for the long-term psychological difficulties that bring people to therapy years or decades after the experiences that caused them. Complex trauma, also called developmental trauma when it occurs in childhood, refers to exposure to multiple traumatic events, typically of an interpersonal nature, typically occurring within the context of important relationships, and typically involving an element of captivity, entrapment, or the inability to escape. The defining features that distinguish complex trauma from acute trauma are repetition, relationship, and inescapability. The events that produce complex trauma are often not dramatic in the way that acute trauma is. They are not single, discrete, overwhelming events. They are patterns: sustained childhood abuse or neglect, repeated domestic violence, prolonged emotional or psychological abuse, ongoing sexual exploitation, growing up in a household organized around a parent's addiction or mental illness, living under conditions of chronic threat in a war zone or a dangerous community. The experience is not one terrible thing that happened. It is a sustained, relational, inescapable environment in which terrible things happened repeatedly over time. The psychological impact of complex trauma is qualitatively different from acute trauma, not simply more of the same but different in kind. Judith Herman, whose landmark work Trauma and Recovery first articulated the complex trauma framework, identified a distinct clinical picture that the standard PTSD diagnosis failed to capture: profound disturbances of self-regulation, including difficulties managing emotions, impulses, and bodily states, alterations in self-perception, including chronic shame, guilt, and the sense of being permanently damaged, disturbances of relational functioning, including difficulty trusting, difficulty maintaining boundaries, and the tendency toward revictimization, and alterations in systems of meaning, including despair, hopelessness, and the loss of previously sustaining beliefs. This is the clinical picture now recognized as complex PTSD, a diagnosis formally included in the ICD-11 in 2018, and representing a significant advance in the clinical recognition of what repeated interpersonal trauma produces in human beings. Complex PTSD includes the standard PTSD symptom clusters and adds 3 additional domains: disturbances in self-organization, specifically affect dysregulation, negative self-concept, and relational disturbances. The treatment implications of complex trauma are significant. The processing-focused approaches that work well for acute trauma are frequently not the appropriate first intervention for complex trauma, because the person with complex trauma typically has a narrower window of tolerance, less access to stable internal resources, greater shame and self-blame, and more fundamentally disrupted attachment patterns that need to be addressed in the therapeutic relationship before direct trauma processing is safe or effective. Phase-based treatment, stabilization first, then processing, then integration, is the framework most supported by both research and clinical consensus for complex trauma. Section 4, Type 3, Chronic trauma. Chronic trauma is defined by duration and persistence, the sustained, ongoing exposure to traumatic stressor that does not resolve, does not end, and does not allow for the recovery period that the nervous system requires to process and integrate what it has experienced. Where acute trauma has a clear before and after, chronic trauma has neither. There is no single event to process, no moment at which the threat ended and safety began. The traumatic conditions are ongoing, and the nervous system, denied the recovery that would allow it to return to baseline, remains in a state of sustained dysregulation that gradually produces its own distinct and damaging effects. The experiences that produce chronic trauma are those that are both harmful and persistent: living with domestic violence that continues over years, enduring chronic poverty and its cascading stressor, navigating ongoing medical illness, inhabiting a community where systemic violence or discrimination is a persistent daily reality, experiencing the sustained stress of refugee status or displacement, or living with a disability or illness that generates continuous, unrelenting demand on the system. The specific neurobiological effects of chronic trauma exposure are distinguishable from those of acute trauma and deserve explicit clinical attention. Chronic stress produces chronic cortisol elevation, and sustained cortisol exposure has documented effects on hippocampal structure and function, on immune system competence, on cardiovascular health, and on the brain's inflammatory processes. The body that has been in sustained threat response for months or years is a body that is paying a measurable biological cost, not just psychological distress but physiological damage that accumulates over time. The clinical presentation of chronic trauma often looks more like characterological adaptation than acute symptom expression. The person who has lived under chronic traumatic conditions for years has not simply been repeatedly injured by discrete events, they have organized their entire personality, their relational style, their cognitive patterns, and their physiological baseline around the demands of surviving in a chronically threatening environment. What looks like character in the clinical room, the hypervigilance that reads the room obsessively, the difficulty trusting any benevolent intention, the somatic complaints that recur without clear medical explanation, is the person as they have been shaped by years of living under conditions that required this adaptation. Treatment for chronic trauma must address both the current conditions and their historical effects, and in many cases, the most urgent clinical priority is safety and stabilization before any historical processing can be meaningfully undertaken. A person still in the traumatizing environment cannot process that environment therapeutically. Safety is not an adjunct to trauma treatment. It is the precondition of it. Section 5, Type 4, Secondary trauma. Secondary trauma, also called secondary traumatic stress, vicarious trauma, or compassion fatigue, terms that overlap substantially but carry some distinctions, is the trauma that is acquired not through direct personal experience of a traumatic event, but through sustained exposure to the trauma of others. This is the trauma of the helping professions. Of therapists, social workers, first responders, emergency medicine providers, journalists covering atrocity, humanitarian workers in crisis zones, lawyers representing trauma survivors, and the families of trauma survivors who absorb, through daily, sustained, intimate proximity, the traumatic material of the people they care for. The mechanism of secondary trauma is both neurobiological and relational. Humans are wired for empathy. Our mirror neuron systems create a genuine, physiological resonance with the emotional and physical states of others, particularly those to whom we are closely attuned. When a therapist sits across from a client describing profound horror, abuse, or grief, and maintains the full, regulated, attuned presence that good therapeutic work requires, their nervous system is not merely intellectually engaged with the material. It is resonating with it. The vicarious exposure is real. And sustained vicarious exposure to traumatic material produces in the helper symptoms that are clinically indistinguishable from direct trauma exposure. Intrusive imagery and thoughts about clients' experiences, hyperarousal and hypervigilance, avoidance of trauma-related material or of the work itself, emotional numbing, cynicism, and the gradual erosion of the beliefs about safety, justice, and human benevolence that sustain effective helping. The distinction between secondary traumatic stress and burnout is clinically important. Burnout is the exhaustion that results from sustained work demands without adequate recovery. It is primarily about depletion. Secondary trauma is about contamination, the specific alteration of the helper's inner world produced by the content of what they have been exposed to. The burned out helper is exhausted and disengaged. The secondarily traumatized helper is carrying traumatic material that is affecting their cognition, their relationships, their nervous system functioning, and their fundamental worldview. Secondary trauma is not a sign of poor professional competence or insufficient boundary setting. It is a predictable consequence of doing work that requires genuine human connection with people in profound pain, and the professional cultures that treat secondary trauma as a personal failure rather than an occupational hazard actively prevent the recognition and support that would address it. Supervision, peer support, adequate time between difficult cases, genuine organizational acknowledgement of the weight of the work, and individual self-care that genuinely addresses the physiological arousal rather than simply distracting from it. These are the evidence-based responses to secondary trauma. For therapists specifically, if you have not had a recent, honest conversation with a supervisor, a peer, or your own therapist about the cumulative weight of the traumatic material you carry from your caseload, this is the prompt. Secondary trauma is not a weakness. But ignoring it is a clinical liability, both for you and for the clients who need your regulated, attuned presence to do the most important work of their lives. Section 6, where the types overlap, and why that matters. The 4 trauma types we have described are categories, not clean compartments. In clinical reality, they overlap, combine, and compound in ways that are important to hold. A person can experience acute trauma within a context of chronic trauma, a single violent assault within a sustained abusive relationship, for instance, producing a clinical picture that has the features of both. A person with complex developmental trauma may later experience acute trauma whose impact is significantly amplified by the existing sensitization of their nervous system. What would be a less severe acute trauma response in someone without prior trauma history becomes more severe in a person whose trauma threshold has already been lowered by earlier experience. Secondary trauma and complex trauma interact in specific and painful ways for helpers with their own trauma histories, a population that is significantly overrepresented in the helping professions. The therapist with unresolved complex trauma who sits with a client's trauma material is not only vicariously exposed to that material. They are potentially experiencing parallel activation of their own unprocessed history, which is one of the strongest arguments for therapists engaging in their own therapeutic work as a professional and ethical responsibility, not merely a personal wellness choice. And the trauma types interact with duration in ways that have specific clinical implications. Acute trauma that is not adequately processed and supported can become chronic through the persistence of its effects. Complex trauma that occurred early in development may produce a nervous system baseline that makes all subsequent stress and adversity more difficult to tolerate and recover from. The clinical implication of all of this is simply the importance of a thorough, curious, non-assuming trauma history. Not a checklist of whether the person has experienced items from the DSM event criterion, but a genuine, comprehensive inquiry into the full range of what the person has lived through, the discrete events and the sustained conditions, the personal experiences and the vicarious ones, the recent history and the developmental one, with the understanding that the map of trauma is larger than any single category suggests. The types of trauma worksheet in the description is designed to support exactly this mapping, for individuals seeking to understand their own history and for therapists building a comprehensive clinical picture of the people they serve. Trauma is not a monolith. It is not one thing that happens in one way and leaves one kind of mark. It is a category that encompasses the sudden and the sustained, the personal and the vicarious, the dramatic event and the invisible daily condition, the wound that announces itself immediately and the one that shapes a person for decades before they have a name for what it was. The reason categorizing matters is not academic. It is practical. It is the difference between a person understanding why they struggle and a person concluding that something is simply wrong with them. It is the difference between a clinician offering the treatment that fits the trauma and one offering a treatment designed for a different kind of wound. It is the difference between recognizing secondary trauma as an occupational consequence deserving of support and treating it as a personal failing requiring toughening up. Every type of trauma is real. Every type deserves to be named. And the person carrying any one of them, or several of them at once, deserves the same thing that all human beings who have been through something genuinely hard deserve: to have their experience recognized for what it is, to have their response to it understood as exactly the right response to the specific conditions they faced, and to have access to the specific support that their specific experience requires. The worksheet is in the description, all 4 types, their definitions, their presentations, and their key clinical features in one organized reference. Share this video with someone who has been trying to name what they have been through. The right name changes everything. And I will see you in the next one.